How's everyone doing today? We are going to call to order the last hearing for the Health and Human Services Subcommittee. Colleagues, we have one readout today from MDH Behavioral Health Administration. And before we get to that, I'll take my time out to embarrass her as many times as I can each day. And just wanted to say that I'm joined by my oldest, Kennedy Corey McCray. And since I've been able to accomplish that, at this time, I'd like to ask for Ms. Naomi Camaro to give us the readout.
Thank you, Mr. Chair. My name is Naomi Camaro. I'm a budget analyst with the Department of Legislative Services, and I'll be presenting on the fiscal 26 allowance for the Behavioral Health Administration. So the total budget for BHA in fiscal 26 is $3.4 billion, which is an increase of $82.7 million from the fiscal 25 appropriation. Page 5 begins discussion of a couple of the performance measures that are included with the annual submission of data that the Department of Health submits to DBM. The first is related to the number of people served by the Public Behavioral Health System, or PBHS. Exhibit 1 on page 6 shows that between fiscal 2019 and fiscal 2024, the total number of individuals treated by PBHS has been increasing, particularly among individuals with a mental health diagnosis. In the analysis, it's pointed out that among individuals with a substance use disorder diagnosis, the increases have been more modest, but MDH indicates that that could be related to a data reporting change in fiscal 2020 rather than limitations to access to care. The second measure included in the analysis is related to the medication for treatment of opioid use disorder, or MOUD. Exhibit 2 at the bottom of page 7 shows the number of said service recipients through the PBHS and the percentage of which are receiving MOUD services between fiscal 2020 and fiscal 2024. Earlier this year, the Department of Health received approval from CMS for a waiver that would cover MOUD services for incarcerated individuals 90 days prior to release. There's $4.4 million in special funds in the budget in fiscal 2026 available through the Opioid Restitution Fund to support this service. MDH should clarify if these special funds are still needed given the recent waiver approval. The third measure discussed in the analysis relates to telebehavioral health. So as you can see from Exhibit 3 on page 9, there's been a major increase in this service between fiscal 2019 and 2020, due mainly to the expansion of a waiver to reimburse for audio-only telehealth services. Subsequent state legislation required the Department of Health to offer this service through June 2025. Starting on the bottom of page 9 through page 11 includes discussion of fiscal 2025 budgetary actions, including cost containment measures authorized by the Board of Public Works in July of 2024, which resulted in a reduction of $9.8 million in general funds to the BHA budget, the largest of which is a $9 million reduction to the 988 Trust Fund due to the availability of special fund revenue from a new telephone fee. This is discussed again in a couple minutes, so I'll come back to that. On page 10, I'll point out there's a couple of proposed, not a couple, there's 9 proposed deficiency appropriations for fiscal 2025 in the fiscal 2026 allowance, including over $150 million in deficiencies for provider reimbursements in fiscal 2025. This is offset by several different general fund withdrawals, which total $53.5 million, the largest of which is a reduction of $30 million due to the delayed implementation of various behavioral health initiatives. There's also a reduction of $3 million for the 988 crisis line. This is contingent on a provision in the BRFA that would eliminate the $12 million mandate for fiscal 2025, which I'll discuss again in a couple minutes. Also on this page, there are a couple of planned reversions in the fiscal 2026 budget plan. There's a planned reversion of $22.7 million in general funds due to unspent grant funding for local behavioral health authorities in fiscal 24, and a planned reversion of $3.9 million in general funds for behavioral health Medicaid services in fiscal 2024. Moving on to the fiscal 26 budget, Exhibit 4 on page 12 shows the total amount of provider reimbursements included in the budget. This is a majority of the budget and totals $2.9 million, the largest of which is allocated to Medicaid services. There's also 3% of the budget, of this portion of the budget, for services for the Medicaid eligible population, and about 8% of this part of the budget for services for the uninsured population. And lastly, there's $19.5 million in the budget for 1% provider rate increase across all 3 provider reimbursement programs. Exhibit 5 on page 13 breaks out the fiscal 26 expenditures excluding provider reimbursements. So about 21% of this portion of the budget is allocated to grants to local behavioral health authorities. There's also $83.1 million in the budget for behavioral health investments, and about $80.3 million for the federal state opioid response grants. Pages 14 and 15 summarize the major changes in the budget between fiscal 25 and fiscal 2026. Again, the total budget is increasing by about $82.7 million. That includes $19.5 million for the 1% provider rate increase. There's also $65.7 million increase due to the timing of state opioid response grants received in fiscal 2026. There's a $14.7 million increase due to substance use services funding moving from the Office of Population Health Improvement to BHA. And these increases are offset by a reduction of over $77.9 million in provider reimbursements, reflecting a decrease in Medicaid enrollment and utilization in fiscal 26. The next page summarizes the state opioid response grants received from the federal government. Exhibit 7 shows the amount that Maryland has received between fiscal 2024 and fiscal 2026 from the state opioid response grant year 3, which ends September of this year, and the state opioid response grant year 4, which ends September of 2027. On page 17, there's a description of the BRFA provisions in the Budget and Reconciliation and Financing Act of 2025. This year, there are 3 provisions in the BRFA that impact the BHA budget. The first is related to the 988 Trust Fund, which I mentioned earlier. This provision would eliminate the $12 million mandate for fiscal 2025. The second would authorize the transfer of excess balances from health occupational boards. DLS made a recommendation in the operating budget for the health professional boards to modify this contingent language and increase the authorized balance transfer to BHA from about $4 million to $10.1 million. The budget bill language would also be modified to decrease the general fund appropriation by this amount due to the special fund appropriation backfilling that. DLS is thus recommending modifying the language on the general fund contingent reduction in BHA to align with the recommendation made in the board's analysis. Lastly, there is a provision related to the Certified Community Behavioral Health Clinics, or CCBHCs. There is current legislation requiring Maryland to apply to the Substance Abuse and Mental Health Services Administration for planning and demonstration grants for the expansion of CCBHCs. The SAMHSA awarded MDH $926,000 in fiscal 2025, but the Department of Health has not yet accepted or declined this award. DLS is asking MDH to indicate if any other funding has been awarded for these grants, and if so, the total amounts. Beginning on the bottom of page 18, there's discussion of behavioral health provider reimbursement. So as I mentioned earlier, there's $2.9 billion included in the fiscal 26 allowance for provider reimbursements, including the $19.5 million for the 1% provider rate increase. However, due to the state's financial condition, DLS is recommending deleting the funding for the 1% provider rate increase in fiscal 2026. The remainder of this section relates to the DLS forecast. DLS conducts 2 forecasts for behavioral health services that are reimbursable each year. The non-Medicaid forecasts are not separated by service level, the way that the behavioral health Medicaid forecast is, and there has been language in previous budget bills requiring the Department of Health to submit this data in order to make the forecast more accurate. And so DLS is recommending adopting committee narrative requesting this information annually to improve the accuracy of regular forecasting activities. Exhibit 8 on page 20 compares the budget with the 3 different programs, with the DLS forecast in the 3 different programs under BHA in fiscal 25 and fiscal 26. And based on our analysis, we have found that there is an $18 million surplus in fiscal 2025 across all 3 programs, and therefore recommend reducing $9 million in the fiscal 2025 appropriation. Page 21 summarizes briefly some of the efforts BHA has taken to address Medicaid fraud, waste, and abuse, including instituting a pause on new provider enrollments for certain services. We have asked MDH to discuss the impact to date on the pause on the number of fraudulent claims that are submitted. The next page includes a summary of personnel data in BHA. The fiscal 26 allowance includes 254 positions, and this includes 5 additional positions in BHA which were transferred from the Office of Population Health Improvement for HIV prevention services and from FIPA for harm reduction services. As of December 31st, 2024, BHA had 41.3 vacancies and a vacancy rate of 18.9%. And of these vacancies, 12.3 have been vacant for more than 1 year. Page 23 begins discussion of the issues in this analysis. So the first is related to behavioral health investments to address the mental health crisis. The Department of Health, or BHA, is required to submit annual data on children and youth mental health services, but has not submitted the report with, or as of this writing, had not submitted the report with fiscal 2023 data. We have asked BHA to discuss the reasons for the delayed reports and when it will submit the 2024 annual report with fiscal 23 data. The rest of this page really briefly summarizes the data in the report that includes fiscal 2022 data. Overall, BHA has indicated that the need for mental health services has increased in the state, as well as the need for high-intensity services among adults and children. One of the tools that BHA is using to address the crisis are these behavioral health investments that I've mentioned a couple of times now. In the past couple of years, there's been a significant amount of funding in the budget for investments in the behavioral health infrastructure in order to address some of the gaps that exists in services. The fiscal 2025 legislative appropriation includes $89.2 million for these investments. And as I mentioned earlier, the fiscal 2026 budget includes a proposed deficiency of $30 million in fiscal 2025. The bullets on page 24 onto page 25 summarize the efforts that are either not being implemented or are being delayed due to this deficiency. The fiscal 26 allowance includes $83.2 million for behavioral health investments. Exhibit 9 shows the spending plan for fiscal 2026. Included in this spending plan are crisis services that are billable to Medicaid, and so DLS is recommending reducing the general fund appropriation by $9.9 million, representing the amount allocated for these services. And we've also asked BHA to clarify why staffing expenditures are included in this spending plan rather than in the personnel section of the budget. On page 27, there's just a description of the Interagency Hospital Overstay Initiative, which is another source of underspending in fiscal 2025. There's fiscal 2025 legislative appropriation included $5 million for the initiative, but the 2026 budget bill includes a withdrawal of $1.9 million in fiscal 2025. The reasons for this withdrawal are summarized at the top of page 28 and include an additional community resource coming online and the termination of a contract that would create 4 residential treatment center beds. DLS has asked MDH to clarify which community resources it anticipates coming online and explain why the contract for the 4 new RTC beds was terminated. The rest of this section summarizes the state plan amendment, which would expand intensive home and community-based services under the 1915I waiver. The second issue in this analysis is the 988 crisis line. So again, the fiscal 2025 appropriation included $12 million for the crisis line, but a subsequent BPW action reduced that amount by $9 million. And then the budget bill this year also includes $3 million reduction contingent on a provision in the BRFA that would eliminate the $12 million funding mandate. The reason for these reductions is due to the anticipated telephone fee revenue. The anticipated revenue is estimated on page 30, Exhibit 10, shows that the comptroller estimates that $13.5 million will be generated from this telephone fee in fiscal 2025. The fee went into effect October of 2024. And the comptroller also estimates that $20.67 million will be generated from the fee in fiscal 2026. This funding supports 6 different call centers across the state that operate the 988 lines. NBHA has indicated that for fiscal 2026, call center funding requests total $23.4 million. Exhibit 11 on page 31 shows the funding actuals from the 988 trust funds supporting the different LBHAs and CSAs that operate the 988 call lines, as well as $1.2 million invested in data analytics. The third issue, beginning on page 32, relates to the assisted outpatient treatment program. 2024 legislation required each jurisdiction to establish AOT programs or for the Department of Health to establish the program in jurisdictions that opted not to establish it themselves. Exhibit 12 includes the work plan that MDH has undertaken, as well as activities that it's done to date to help set up the program, including hiring a director for the program, reviewing other states' approaches to providing AOT services, as well as creating a recommended implementation strategies for jurisdictions. The fiscal 2025 appropriation and the fiscal 26 allowance each include $3 million in general funds for the startup of the program. MDH released an RFP in November of 2024 asking local jurisdictions to submit spending plans, but as of January 31st, 2025, no jurisdictions submitted these plans. MDH has also indicated that a majority of the services included in AOT programs are billable to Medicaid, and so we've asked MDH to provide an approximate percentage of services included in an AOT program that are billable to Medicaid. We have also asked MDH to explain its plan to implement this program, given that no jurisdictions have submitted proposals or spending plans or indicated their intention to administer the program locally. I'm going to take a second to drink some water. Yes, okay, thank you. That's a lot of talking. Okay. So the fourth issue included in this analysis relates to the behavioral health workforce. Legislation in 2023 established the Behavioral Health Workforce Investment Fund and also required the Maryland Healthcare Commission to conduct a comprehensive behavioral health workforce assessment. The findings of this assessment are included on page 35 and 36, as well as the recommended strategies to address some of the findings. MDH has indicated that it's been developing a work plan to implement some of these strategies, and DLS has asked MDH to share a timeline for completing this work plan, as well as plans to share the work plan publicly. The final issue discussed in this analysis relates to the recoupment of provider payments and the transition to the new behavioral health ASO. On page 38, Exhibit 13 shows the amount of funding that was left to be recouped due to the provider overpayment situation in beginning in fiscal 2024. That total was $359.6 million. And as of December 2024, the Department of Health had recouped $300.6 million of that related to claims, and 78.4 out of $81.5 million related to negative balances. The remainder was either forgiven or referred to the CCU for collections. The next couple of pages summarize the transition to the new ASO, which went online January 1st of this year. All of the information included in this section of the analysis was in response to budget bill language that restricted funding pending the submission of a report. And DLS has determined this report to be in compliance with the language, and so recommends the release of the $250,000 as long as there are no objections raised by the subcommittees, and can process a letter to that effect. Finally, the last paragraph on this page briefly talks about the contract costs with the ASO. Fiscal 24 actuals include $33.4 million for the ASO contract for Optum, the former ASO, and the fiscal 2025 working appropriation includes funding for both Optum and the Carelon contracts, as they had to overlap to aid with the transition. However, the fiscal 2025 working appropriation for the contract costs under BHA total $31.96 million, and MDH has indicated that the contract costs related to Carelon were actually budgeted as a major information technology development project in the Medicaid budget. And so we have asked MDH to clarify why the final 6 months of the Optum contract cost nearly the same amount as a full contract year in fiscal 2024 actuals. Finally, I'll summarize briefly the recommendations from DLS. The first is to modify language on the general fund appropriation related to the board balance transfer from the health professional boards to BHA. The second is to restrict funding pending submission of the reports on provider reimbursements. There's also a recommendation to reduce $9.9 million of funding for the behavioral health investments, a recommendation to delete $19.5 million for the 1% provider rate increase, a recommendation to reduce $9 million in fiscal 2025 in provider reimbursements, and then several pieces of annual language that would authorize funding to be transferred throughout between the different behavioral health provider reimbursement programs. And with that, I can take any questions.
Seeing no questions at this time, I think that it's appropriate to call up Deputy Secretary Moran and Dr. Lloyd and the respective team members that you were going to bring.
We ready to go? All right. Good afternoon, Chair, committee members, Ms. McCray. I want to thank you for the opportunity to talk about the Maryland Department of Health's proposed budget for behavioral health and the alignment of funding to support the Moore-Miller administration priorities to achieve a world-class, high-quality health system that provides whole-person care and treats everyone with respect, compassion, and delivers on improved health outcomes and experience. My name is Alyssa Lord. I have the privilege of serving as the Deputy Secretary for Behavioral Health. I am here today to discuss the work of the department that we've undertaken to build the behavioral health continuum of care. The department is looking upstream to better meet the needs of youth and their families. On February 17th, 2025, the department submitted to CMS the revised 1915I state plan amendment. Key highlights from the submission include addition of youth peer support services, increased service capacity to reach more youth, extended plan of care review periods, lowered eligibility criteria to improve access to care, preservation of the Telehealth Access Act to maintain remote service options. Secondarily, the department is partnering with Maryland Coalition of Families and Manat Health to develop recommendations through a public-facing roadmap that offers a vision for change for the state's public behavioral health system for youth and their families. With that, I will turn to brief highlights of our written responses to the DLS questions. In response to the request for clarification if the ORF funds are still needed, given the recent waiver approval enables the department to leverage the federal assistance match for these services. ORF funding is needed for the state share of services. In response to the recommendation regarding the Health Occupation Board revenue sweeps, MDH would like to refer to the testimony from the Health Occupation Boards in opposition to this DLS recommendation. In response to the question if any other funding has been awarded for CCBHC grants, no other funding, inclusive of grants, have been awarded for CCBHCs. Participation in the planning and demonstration grant creates a significant budgetary obligation for the state to move forward with implementing benefits. Services must be covered for both Medicaid and uninsured and underinsured. As per the analysis, the department estimates that it would cost $227 million to implement and support CCBHCs in 2027. Other states, such as Missouri, that have implemented CCBHCs, has seen cost of $496 million annually. The department acknowledges the recommendation of the deletion of the 1% provider rate increase with an amount of $19.5 million in fiscal year 26. In response to the recommendation of adopting an annual committee narrative with utilization and enrollment information, the department proposes we will post the monthly ASO data files in the virtual data unit in lieu of annual utilization and enrollment reports to improve the accuracy of regular forecasting activities. This is a practice that already exists in BH Medicaid, Somatic Medicaid, and DDA. The department respectfully disagrees with the DLS recommendation to reduce the fiscal year 2025 general fund appropriation for program LO103, state-funded Medicaid services, by $9 million. BHA's second quarter projection shows a $2.1 million deficit after factoring in the negative $3.1 million deficiency item. In response to the request to discuss the impact to date of the pause on new provider enrollment on the number of fraudulent claims submitted, given that providers have up to 12 months to submit claims, the full impact of the pause on fraudulent claims for PRP, PRP Health Home, PHP, and IOP may not be fully realized until December 2026 to allow for full claims runout and conclusions of ongoing investigations. A table detailing all the referrals made since July of last year is included in the department's written testimony. In response to the status of the report on services for children and young adults, the report was submitted on February 24th, 2025. MDH apologizes for the delayed submission. The department respectfully disagrees with the DLS recommendation to reduce the general fund appropriated by $9.9 million for crisis services. MDH acknowledges that the current spend plan for these two items does not account for federal reimbursement, conservatively estimated at $4.9 million. The BHA funding provides support for these state share costs. Taking this reduction would eliminate state budget support for these initiatives, leaving them unfunded. The department respectfully requests to maintain full funding for the spend plan to account for continued investments in programs that serve youth and families, such as the Behavioral Health and Pediatric Primary Care Program, which has been in existence since 2012, interagency hospital overstay to address adolescent department and inpatient overstays, which is pending fiscal year 2026 Senate Bill 696 and House Bill 962 legislation, and investments in programs to address the court-ordered wait list. In response to which community resources MDH anticipated coming online to replace spending in the pediatric overstay program. Through a partnership with Brook Lane Hospital, MDH established 7 beds with an additional 7 inpatient beds slated for March 2025. MDH also established 15 adolescent inpatient substance use disorder beds. The department has also invested in rate increases for providers for EPSDT, As mentioned above, enhancements to the 1915I State Plan Amendment, and the billing of school-based mental health services through Medicaid. MDH continues to evaluate the continuum of care for children and adolescents, including residential beds and other levels of care. In response, to provide an approximate percentage of services included in the AOT program that are billable to Medicaid. At this time, we are unable to generate a firm estimate of this percentage because the volume of clinical services received will widely vary. Within these constraints, MDH expects that over 50% of AOT services will be billable to Medicaid. I would refer the committee to our written responses for a full update on which services are billable to Medicaid. Continuing with AOT, MDH is in the preliminary stages of determining its implementation for a statewide MDH-run AOT program, which will be implemented as a regional approach. This strategy has been devised in part as a result of no jurisdiction electing to implement AOT. Preliminary plans include drafting regulations, developing a staffing plan, program materials, and increasing stakeholder engagement. In response to the request for MDH to share a timeline for completing the Behavioral Health Workforce Assessment Work Plan, the Maryland Healthcare Commission, MHCC, in collaboration with the Department of Health and Department of Labor, are engaged in the development of a request for proposal for a vendor to work with the state on the next steps in implementation. It is anticipated that the state will work with the vendor throughout the remainder of calendar year 2025. The department thanks DLS for the recommendation to release $250,000 in general funds that were restricted in fiscal year 2025, pending the submission of the report on the recoupment of provider payments and an update on the ASO transition. In response to the request to clarify why the final 6 months of the Optum contract costs nearly the same amount as a full contract year in fiscal 24, the department respectfully disagrees and seeks clarification from DLS on their analysis related to contractual payments. MDH would like to refer back to our written testimony for the invoices and totals that have been paid to date on the Optum contract. Lastly, the department respectfully disagrees with DLS's recommendation to restrict budget realignments. The restriction proposed by DLS places undue stress on the budgeting process and impedes MDH's ability to internally address budget shortfalls. At a minimum, MDH urges the General Assembly to allow for budget realignments within Medicaid programs to include Developmental Disabilities Administration Community Service. If projections turn and Medicaid or DDA waiver program costs run higher than budgeted, realignment limitations lead to situations where provider payments are halted if general fund appropriation is fully expended before closeout, and we are not able to realign available appropriations from elsewhere within the department. This flexibility is important to maintain moving forward and is especially needed now when budget pressures disallow inclusion of any other cushion that would allow for changes in enrollment, utilization, and other drivers. I thank the committee members for their time and welcome any questions.
Senator Hedelman.
Thank you very much, Mr. Chairman. Thank you, Deputy Secretary. Really appreciate your being here and for your comprehensive overview. I would appreciate if you could talk, I want to talk about two issues. One is, the first is the CCBHCs. And was there an expectation that you would move forward with that? It said in the analysis that you were required to apply for the planning grant. And given that it's almost $1 million, which it turns my stomach to have to return any federal money, no less of that amount. I guess if you could talk a little bit about kind of, because that seems like a direction that we need to go into, and they provide much needed services in the community. And so, and they have existed. So I'm sort of, can you shed a little more light on that process for me?
So thank you and appreciate the questions that are Hedelman.
Sorry, one more question. And you mentioned in terms of the increased costs that you would expect from implementation, you said the department, and the analysis is based on information that MDH gave them. So when you meant the department, did you mean MDH or did you mean DLS?
So to respond to your second question first, so that was, the information that was provided to DLS was included in the fiscal note.
Right, but they
From the department.
referenced that it was.
From the department.
Your department, okay.
Yes,
Gotcha.
yes,
I
from
just
the
didn't know
Maryland
which
Department of
department
Health.
you meant.
Yes,
Okay,
from the
that's
Maryland
helpful.
Department of Health, yes.
That's helpful, thank you.
So the legislation required the Maryland Department of Health to apply for the planning grant, and subsequently within the legislation, it also requires the department to participate in any subsequent demonstration grants. And so given the current state of the state as it pertains to the budget, it is difficult to make the decision when the state is facing a $3 billion deficit as to, you know, which services are going to be implemented. I will say for the existing CCBHCs, they will be able to continue to offer services. There's no disruption to care. They will be able to continue to bill for the services that they are currently providing under their existing licensure. So we don't anticipate any disruption to services or care if we are unable to proceed with the implementation of CCBHCs.
But doesn't that by definition cut the funding stream to them?
Yeah, thank you, Senator Huddleman, for your question. So the federal demonstration grant is a planning grant, departmental resources, the $1 million that you cite, that enables us to work in terms of getting up and funding for the particular sites. And then when you look out in terms of the implementation of that, just as Deputy Secretary Lord cited, I mean, the upfront investment around $227 million total funds. So while we have these enabling funds of grants, the fiscal year 27, if we move forward with the demonstration with which the legislation requires us to, does obligate it for a full funding implementation of that. We recognize that we do not take this decision lightly in terms of what this particularly means. We have also done our due diligence to look at the demonstration opportunities that have happened with other states that have gone before, trying to understand what are some of the long-term, if you will, outcomes and savings. Largely they are mixed, and we're happy to provide the committee data around some of those states that have gone before. And so, you know, as Alyssa mentioned, the opportunity here around budgetary obligation for 2027 that would require the state to move forward with implementation of those is tough given our current budget situation.
Okay, I think I'd like to follow up offline about that. And if I could have a second bite at the apple, Mr. Chairman, could I raise another issue? Thank you. So I recently learned about a memo that went out on Friday for the Maryland Recovery Net and Client Support Services, and that froze funding for that budget. And I wonder if you could tell me a little bit about what the budget was for FY25, what the reasoning was for the sudden decision to kind of halt it in its tracks, what the expectation is for FY26, and if there is a plan to move forward, do you plan to engage stakeholders in trying to assess where the issues lie?
Yeah. Again, appreciate the question, and this was a difficult decision that the department needed to make to ensure that we aligned with fiscal solvency. So we have seen increases in certified recovery residence beds year over year, and while we have attempted to adjust the budget accordingly, based upon our projections, if we continued to fund MDRN at the rate that we were funding, we would enter into a deficit before the end of the year. So we provided 30 days notice to our providers to let them know that no authorizations and no new applications would be, no new authorizations beyond March 31st would be authorized for payment, as well as no new applications for MDRN providers would be approved. In terms of moving forward, as we do for prior years, we look to our projections to determine how we think we need to look at our growth and utilization to attempt to budget accordingly. And our team will be undertaking, and has already begun, Senator, a process of meeting with our recovery residences We do need to set some additional parameters around performance, outcomes, and length of stay so that we are certifying quality providers in which we will demonstrate the health outcomes that we all hope to see for individuals that are receiving services through recovery residences.
Could you tell me under what pot of money is this program?
State general funds.
State general funds. And how much has been spent so far?
Can I take the question for the record and get back to you?
Sure. Okay, thank you very much.
Thank you, Senator Hedelman. Senator Zucker.
Thank you very much, Mr. Chair. Good to see you all. I had a quick question, or maybe you can help give the subcommittee some guidance. So given all the chaos on Capitol Hill in Washington, is there any trends that you're seeing within the agency that we should be aware of as policymakers in terms of phone calls you're getting? Just sort of a lay of the land that might not be reflected in the analysis? I know that's a multi, and I want to be sensitive that the work that you do is nonpartisan, non-political.
Yeah.
But and the people you serve are we're serving people regardless of political affiliation. But I was just trying to, just for our standpoint as public servants, is there anything that we ought to just be keeping a mind on given the changes in DC, both from a administrative and sociological standpoint?
Yeah, I'm happy to, give the perspective from a global view related from a Medicaid perspective, and then have Deputy Secretary Lord if there's any additions to add related to the actual people that we serve, because we also know this has, multi-level layer impact. What I would say, Senator Zucker, is we are watching things very closely in terms of the impact here. Obviously, largely mental health services is Medicaid remains its number one driver, number one funder in terms of the country related to the services and the provision of care. So all of the particular elements that are talked about from a state perspective that would impact states certainly would impact the behavioral health space for us as well. We've talked about many of those in terms of what that risk is here, right? If you will, the 90 to 10% match on Affordable Care Act expansion adults obviously would impact this population as well. And then, anything related to some of the changes in eligibility requirements or standards would obviously have an enormous impact here in terms of coverage for individuals. And so we're watching those very, very, very closely. Obviously, last week, in terms of the movement, the vote that the House made in terms to move forward, we will see if there can be some divergence in terms of what the Senate may feel in terms of these particular items, because largely, and a credit to the individuals who are here as stakeholders in this room, it's a very serious time for the program and a very serious wave to keep our eyes attuned to what may happen at the federal level and the impact. So it certainly impact our provision of services from both a federal perspective, but also the investments, right, that we make in the uninsured BHA space when we're talking about the dollars and the cents that are available to truly meet the needs of and the communities that we serve.
Yeah, and it's certainly a team effort. So if there are things that you think we could be helpful with, obviously we have an executive who can in the state who cares about people and can do things, has some flexibility. But while we're in session, just if there are things that you think the subcommittee or the Senate can be helpful with, please let us know, because this is where, Mr. Chairman, we have the most leverage is during session. Thank you very much.
We appreciate that greatly. I would just, also say we are, in the process of, there's been lots of policy proposals floated. We are waiting for the specifics that would allow us to sort of start wrapping our arms truly around these means, and thankful as always for this committee's partnership in that regard, Chair McCray.
Thank you both. Just a couple questions. The first one is, we're looking at page 2 of the written testimony provided by the department. Due to the state's fiscal condition, DLS recommends deleting $19.5 million, representing the 1% provider rate increase. You guys acknowledge it, but it didn't feel like you guys took a position.
So this is a decision ultimately that needs to be made by the members of the General Assembly. So we acknowledge it, but from an appropriation standpoint, that falls within, unfortunately, your trusted hands.
Got it. Yeah. The second one is because there's going to be a number of folks coming behind you, being able to read their written testimony. If you can you just give the department's thoughts, comments, in reference to 988 and the budget reduction?
Well, we are happy to provide an update that the 988 funding will be in the supplemental budget.
Got it. Can you provide thoughts and comments in reference to the transition of the new ASO?
So I will say it works. Now, with any large-scale transition, there are going to be challenges and opportunities in that journey. So we are, our check runs are mirroring what they did prior to the transition. So providers are getting paid. There are some adjustments that we needed to make early on and continue to make with Carillon. There have been some provider patches or fixes that have needed to be made. There are additional provider education and training that is going on regarding our claims rules and how to drop and get paid for claims appropriately. And we continue to meet with Carillon on a regular basis. Also, Carillon has brought on a large number of additional assets and resources to support this transition. So we're going to continue to monitor it very, very closely to make sure that our providers get paid, but also that the Marylanders that are receiving services through our provider community are getting high quality and equitable care.
Thank you. And the last comment or thought, if you can comment or give your thoughts, the agency's thoughts in reference to the behavioral health workforce shortage.
So Maryland is not, unfortunately, like any other state who is facing a behavioral health workforce challenge. And so we look forward to continuing to see the output that comes out of the work that the MHCC has undertaken in partnership with the Department of Health and the Department of Labor regarding the recommendations that have been put forth. We also think that this is a keen opportunity to partner with our provider community to make sure that we are building and maintaining through attracting and retaining talent in Maryland. And so, you know, this is going to continue to evolve over the next several months.
Thank you. Seeing no further questions, we do have a number of folks that's going to give public testimony. So I'll give my comments towards the end, and we'll start to give up the names, to call up the names for those giving public testimony. Colleagues and those in the audience, we're going to call them up in fours. Is what we'll do, and we'll start with Carrie Graves, Gus Hughes, Michelle Grigsby Hackett, and Adrienne Breinstein. And please, whoever wants to start.
Good afternoon. I'm Adrienne Bridenstine. I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore. I want to thank the committee for the opportunity to speak with you today. Here in support of the Behavioral Health Administration's budget, we are grateful to hear that the 988 funding is coming in the supplemental, and we'll look forward to seeing that. You'll hear from other providers today, but I just want to thank the committee and the General Assembly and the department for their work that they've done on 988. Maryland is a great position. Our 988 call centers are strong. In Central Maryland, we pick up the phone in 17 seconds. So I think that's partially, we do so well because of the investments that this group made and the work that's been done at the local level and with the department. I also want to thank MDH for including the behavioral health, $5 million for the behavioral health crisis grant in the FY26 budget. You'll also hear from others on how we use that, but I can tell you in the city, we use that to expand our mobile crisis team so that we have overnight coverage. And then finally, just want to ask this committee to protect the 1% that's included in the budget. You'll also hear from others today on why that is so important, but workforce is one of those reasons. Inflation is another, among many others. Thank you for the opportunity and happy to take any questions.
Good afternoon, Chair McCray and committee members. My name is Michelle Grigsby Hackett, and I'm the CEO of Affiliated Sante Group, Maryland's largest behavioral health crisis response and outpatient provider. I'm here today to urge you to protect funding for the Mobile Response and Stabilization Crisis Services. First, I would like to thank the administration for ensuring the allocation of the Behavioral Health Crisis Grant funding for FY26, as well as confirming the supplemental budget for the 988 telecom fee to support call center operations. Mobile Response and Stabilization Crisis Services, also known as MRSS, are a specialized youth and family crisis response. Since 2021, Sante has delivered the MRSS services in 5 Eastern Shore counties in Maryland and has been responsible for reducing emergency room visits, hospital admissions, and juvenile justice involvement. In just 2 years, we've prevented 381 law enforcement interventions, 140 youth have been diverted from emergency petitions, and we've kept 137 youth out of emergency departments while linking nearly 1,000 individuals to stabilization services. Cutting MRSS funding will likely increase long-term costs as families will turn to higher cost and burden systems like emergency departments, which already have the highest wait times in the nation, and they'll also turn to 911 and risk entering the criminal justice system. We urge the General Assembly to sustain funding for critical MRSS programs. Thank you.
Good afternoon, Senator McCray, and to the committee. My name is Carrie Graves. I serve as the Executive Director for the National Alliance on Mental Illness, NAMI Metropolitan Baltimore, and we, along with our partners at NAMI Maryland, respectfully request amendments to the proposed FY26 budget for the Behavioral Health Administration. We are a nonprofit organization providing education, support, and advocacy to individuals who are living with a mental illness, their families, and the wider community. We operate a warm line for individuals in need of mental health resources, and oftentimes we are referring callers to the services that 988 provides. We're offering for them to call 988 when they are in crisis or in immediate need of services. We understand that there will be a supplemental budget to include 988. We ask that that is fully funded. It is an incredibly important service. So that is of concern to us, not existing in the budget as it stands right now. We also agree that that 1% provider increase is incredibly important. The workforce in our behavioral health community is already at a shortage. So we do recommend including that in the budget and not taking any further cuts. And additionally, NAMI Metro respectfully urges the Department of Health to accept the nearly $1 million already awarded for the CCBHC expansion. People living with mental health conditions, their families and communities across Maryland rely on all of these programs, which are already underfunded. So, cuts or reallocation of funds within the proposed BHA budget will lead to lower quality mental health and behavioral health care across the state. And I'd like to, if I could, transfer any remaining time that I've got over to Gus Hughes, who is one of our NAMI Metro Baltimore advocates, here to share his lived experience with you all today.
Hello, my name is Octavius Hughes. I go by Gus. I have used 988 in the past 10 years numerous times. The most recent time being was last May, and I genuinely think if I wouldn't have called 988, I wouldn't be here. So I can give more?
Yes,
Okay,
yes,
sorry.
Yes.
Last year when I used 988, I was at the time living in a motel along Route 40 in Baltimore County. I had lost access to my primary care doctor, my therapist, and psychiatrist all back to back to back. I had very little access to my medication at that point. And during that time, while I was in the motel, I went through an experience where I was nearly assaulted. And I think if I wouldn't have had, 988 to be able to call while I was in my crisis, my roommate, who I was currently homeless with at that time, they would have probably found me dead somewhere, either in the hotel or outside of the hotel. And unfortunately, my case is not the only case in terms of using 988. Even just last year, I've lost one friend to suicide. I know many of my friends have called 988, and unfortunately, in the current times that we are in, I think if these, services get cut off and they are not fully funded, even in the supplemental budget, more people are going to lose access to services like 988, and it's going to be detrimental to Marylanders. So thank you for allowing me to speak, and I'll turn it back to you.
Before I call up the next group, I just want to acknowledge that in another life, Madam Chair, it's always good to see you. And just wanted to thank you all. At this time, colleagues, we're going to call up Nicole Granner, Dan Martin, Carrie Guthrie, and Neil Donnelly.
Okay, Mr. Chair, Senators, Dan Martin with the Mental Health Association of Maryland here in support of full funding for the Behavioral Health Administration. And I just want to start by thanking BHA and their staff for everything they're doing. They're really doing the work to kind of improve and modernize Maryland's behavioral health system of care. They're doing great work to build out the crisis response system and the children's system of care for children and youth. And that work needs to continue. And so I'm here today to just ask for a few things. One, please preserve the 1% increase in provider reimbursement. You heard the workforce data. Our behavioral health workforce is 50% smaller than necessary to meet today's demand, and 45% of the workforce is expected to leave the field in 3 years. And we have this data thanks to legislation that you all passed a couple of years ago. And we're happy to hear that BHA is developing a plan to address the recommendations in that workforce report, but we'd be taking a step backwards before we even get to that plan if you cut this provider rate increase. Providing competitive compensation is the #1 recommendation in that report, which is no surprise when many in the behavioral health workforce do not even make a living wage. And the second thing I wanted to ask is to please allocate $5 million to maintain existing youth crisis response capacity. This is the program that you heard about earlier. BHA is currently delivering MRSS services in 11 counties across the state, addressing huge gaps in Eastern Maryland and the Southern Maryland and the Western Maryland. It's a key tool in efforts to reduce avoidable youth psychiatric emergency department visits, unnecessary hospitalization, and preventable criminal justice involvement. But it's funded with ARPA dollars that go away soon. And we'd hope that you would, again, allocate $5 million to continue that funding. And I just want to close, take a moment of personal time real quickly to just recognize the amount of people in this room that came out to support this funding. You can see they all have their budgets, their buttons on, and I want to give a shout out to the people that waited in the lobby. The lobby is packed right now too. Again, I want to just, again, recognize all the people that drove so far from all different areas of the state to come out and support, full funding for mental health and substance use care across Maryland. And just in closing, I wasn't able to make the Health Regulatory Commission, but please protect the school mental health funding through the Consortium of Coordinated Community Supports too. I know a lot of people were here for that as well. So thank you for your time, Mr. Chair.
Chair and members of the committee, thank you for this opportunity to testify today. My name is Neil Donnelly. I serve as the Executive Director for On Our Own of Frederick County, a peer-led wellness and recovery center, one of 23 across the state affiliated with On Our Own of Maryland, dedicated to supporting individuals facing mental health and substance use challenges. I urge you to support and maintain the proposed FY26 Behavioral Health Administration budget to ensure that organizations like ours continue providing critical peer-driven services that save lives and rebuild futures. Every day, we help Maryland residents access mental health and substance use treatment, navigate essential resources, and to find hope in recovery. For example, take Victor S. He's a 72-year-old who relapsed, but with peer support, found stability. Today, he's thriving. He's transitioning into income-based housing, he's obtaining a driver's license, he's training for a new job, he's maintaining his sobriety. He's proof that recovery is possible at any age when the right support is in place. In FY25 alone, our organization has directly connected and assisted individuals in securing inpatient treatment, while many more peers receive life-saving peer support to combat potential overdose and suicide. These aren't just numbers. They represent people. Low-resource community members, family members, and friends deserve a chance at a healthier and a more stable future. Sustaining funding for wellness and recovery centers means sustaining recovery for Marylanders. I urge you to invest in proven, cost-effective peer support, services that keep people alive, housed, and thriving. Thank you for your time.
Good afternoon, Chair McCray, members of the committee. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. We represent 87 community-based providers delivering essential mental health and addiction services across Maryland. I'm here today to urge you to prioritize the full implementation of the Certified Community Behavioral Health Clinic model and protect the 1% increase in the governor's budget. Maryland's compensation for social workers and counselors lags behind our neighboring states. The 1% increase, though modest, is crucial to retaining our workforce and ensuring access to care. The CCBHC model is a proven, comprehensive approach that integrates mental health and physical health care. It reduces hospitalizations and expands access to care. The clinics already operating in Maryland have demonstrated successful outcomes and improved access to services. We are aware that Maryland's projected year-one costs are double those in 3 other states and nearly 10 times higher than New York. We welcome the opportunity to better understand these projections and work collaboratively with the department to find the most efficient path forward. One approach could be to start with a smaller number of clinics and delay the start of the demonstration until FY27, which would help control costs while ensuring successful implementation. Additionally, we urge the committee to allow the incoming health secretary the opportunity to evaluate the efficacy of the CCBH model for herself before making any further decisions. We simply cannot afford to miss this opportunity. If we don't act now, we risk losing more professionals from the field, exacerbating the behavioral health crisis. By protecting the 1% rate increase and fully implementing the CCBHC model, we can strengthen our workforce and ensure Marylanders get the integrated care that they need. Thank you.
Good afternoon, Chair McCray and committee members. My name is Carrie Guthrie, and I am the President and CEO of Cornerstone. We are in all districts, including Senator Zucker's in Montgomery County, and I'd like to thank and recognize the staff and clients who came with us today for support. Cornerstone is one of the 2 original organizations in Maryland to receive a SAMHSA CCBHC expansion grant. In fact, we've successfully received 3 grants, so that over the last 6 years, we've been able to position ourselves to be a key partner with the state of Maryland in the implementation of CCBHCs. One CCBHC priority is access to care. We purchased translation technology, which allowed us to expand translation services from 904 minutes to over 15,000 minutes in 21 different languages to make it easier for people to access services, because language certainly should not be a barrier. Improving health is also another priority for CCBHCs, and we added certified nursing assistants and a licensed practical nurse to help over 200 clients who are aging in place. As a result, we saw a reduction of 36% in hospital admissions and 59% in emergency department usage, plus an improvement in blood pressure, and we had quite a few clients who quit smoking. It is important to note that these critical services are not reimbursable under the current Medicaid fee-for-service structure. So that means without the sustained funding through a CCBHC, we would not be able to continue to provide these services, and that would be a loss of effective healthcare services, certainly for many of our clients who age in place. CCBHCs have fundamentally changed behavioral health care in the states where they've been fully implemented, and we ask you to restore the language obligating the Department of Health to pursue the planning grant and apply for inclusion in the demonstration program. Thank you.
And thank you. Seeing no questions, colleagues, I'm gonna call up the next 4: Kathleen Kirk, Rebecca Redmer, Demetrius Kabathis, and Damian Lang. look like we are missing one person. Is Kathleen? Kathleen Kirk?
Katie Kirk's not going.
Okay, perfect. We'll call up Betty Capano.
Good afternoon. Can I start? Good afternoon. My name is Rebecca Redmer. I am a certified family peer support specialist with the Mobile Response Stabilization Service with the affiliated Sante Group. My passion for youth, mental health, and community is what led me to crisis work. And it's no secret that in today's world, all of the above are in a state of crisis. Maryland has a shortage of behavioral health workers, and the demand is continually increasing. We see this impact of the shortage everywhere in our community. We cannot, as a state, allow a cut to this budget at such a crucial time. In my work with youth and families in crisis and stabilization, I see the immediate need for the 988 line and crisis teams. Families need help and they don't know where to go. The wait time for mental health therapy is long, the requirements for emergency petitions are stringent, and there is a lack of beds for inpatient. And for some families, they simply are overwhelmed and have no idea how to get help for their loved ones. I know this personally as well as professionally, as I have been on the other side, needing to call 988 and crisis teams to help navigate mental health episodes for my husband, a first responder of 20+ years who battled PTSD and depression. His mental health recovery journey began because of a call to mobile crisis. We had tried as a family to help him until we no longer could. In December of 22, my husband was suicidal. He had lost all hope. Because of that one call, his life was saved and our family's healing began. We reached out during a time when suicide was the only option for my husband. We couldn't find a therapist. It was the middle of the night, and he didn't meet the criteria for emergency petition. All we had was the number of the local Maryland crisis team. Within 48 hours, he was at an intake appointment and accepted into a 6-week program specialized for first responders. Without that call or visit, the resources they shared that night could have looked a lot different for our family. Our family story is one of many, and many more common than not. In Maryland alone, 781,000 adults have a mental health condition. To put that in perspective, that's 19 times the population of Annapolis. 252,000 adults in Maryland did not receive the needed mental health care. 33.7 did not receive it due to costs. 1,082,305 people in Maryland live in a community that do not have enough mental health professionals. Statistics like this shows the reality of the need for funding for programs such as mobile crisis, MRSS, and call lines. In my work with the community, I sit with parents and caregivers and kids when they are at their lowest, a time when their hope is dwindling, their patience is gone, and they are exhausted. They feel alone and lost. There is a small time frame, a small window of opportunity that can lead to very different outcomes. Mobile crisis teams, MRSS, and the 988 line are all interventions needed. And without these interventions, our already overwhelmed systems, including the education, the hospital, the court, and the prison system, will continue to struggle with the demands of mental health. Thank you.
Thank you.
Good afternoon, Chair McCray and committee members. My name is Damian Lang. I'm the State Government Relations Director for Shepherd Pratt. I'm actually joined by some of my fellow colleagues from Shepherd Pratt. So if you're here from Shepherd Pratt, if you could please stand and show your support. Let's see how many folks made it from the lobby. All right. Well, we have a lot of folks in the lobby as well. Thank you all. We understand the difficult nature of the state's current fiscal situation. However, we urge this committee to ensure that critical behavioral health services remain fully funded by addressing the following concerns. We ask that you protect the 1% provider rate increase for behavioral health services. We strongly oppose eliminating this increase in the governor's budget. Maryland faces a severe behavioral health workforce crisis, with half the current workforce expected to leave in the next 3 to 5 years. Without adequate provider rate increases, Marylanders will struggle to access care. Maintaining this increase is essential to stabilizing community programs and retaining behavioral health professionals. We also ask that you preserve the path to statewide CCBHCs. We oppose eliminating statutory language which requires Maryland to expand CCBHCs statewide. The CCBHC model provides integrated mental health and substance abuse services while reducing hospitalizations. Maryland has seen positive outcomes from our existing CCBHCs, and halting progress would certainly severely impact access to care. We also ask that you oppose Medicaid cuts that harm behavioral health access. Proposed Medicaid cuts threaten critical services, including the collaborative care model, which integrates mental health into primary care, and the supportive housing waiver, which serves individuals experiencing housing insecurity and behavioral health conditions. Cutting these programs will increase emergency room visits and worsen health outcomes. You all have my written testimony, which is much longer and goes into detail into all of this, so I'll end there, and thank you so much.
Hello, my name is Dimitri Kavathis. I am the CEO of HealthPort, and we provide primary care and behavioral health care to the Lower Eastern Shore to over 2,000 citizens. And we're here today to tell you to please keep the CCBHCs. We are one of the CCBHCs that provide wonderful services. And in my written testimony, I've actually submitted data from CRISP that shows significant hospital savings of over $2 million. I think also what you haven't heard is that across the country, there are over 500 CCBHCs providing services in over 46 states. So this is the new model of value-based care. I do want to commend the department for restoring $600,000 in value-based models of care. And CCBHCs are just a wonderful way to continue to facilitate this kind of quality service for the citizens of Maryland. I'm really imploring you to really think about amending the rules to accept the $926,000 that have been awarded, to plan this out, and then give a window to the department so that they have flexibility to implement this in a way that can be budgetarily sensitive. Thank you so much.
Thank you, Chair and committee members, for your work to improve healthcare in Maryland. My name is Betty Capano-Williams. I am here today representing owner-owned of Calvert County and St. Mary's County. These are peer-operated wellness and recovery centers that provide free walk-in support service to people living with mental health and substance use disorders, complex disabilities, and those who are homeless. We also help many that are illiterate. We are funded through BHA and are affiliated of Owner-Owned of Maryland Network. We urge you to avoid cuts to grant funding, behavioral health programs like ours, and to maintain 1% budget increase. Our centers have provided incredible value to our community for over 25 years. Thanks to them, I have been clean and sober for 4 years. They gave me support, understanding, and community when I needed it the most. Now I serve as an active board member. Last year, we served 400 people as a non-clinical program. We employed peer specialists that help each person achieve their recovery goals. We help people meet their basic needs, gain housing, employment benefits, and health insurance. We also provide education and whole health support. Our services are a safety net for so many who are not able to access services because of barriers. We offer compassion, purpose, love, and help to people to help them heal and recover. We urge you to present cuts to the BHA budget. Thank you for your continued support.
And thank you. At this time, colleagues, we do have one last person, Ms. Jane Krinke. And I also wanted to recognize if there is anyone in the crowd that may have had trouble with the system, feels some form of an obligation to give some level of oral testimony, this is your moment to come up to the stage. No.
Hi, good afternoon. Chair McRae, members of the subcommittee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association just to provide information pertinent to the BHA budget. Maryland's hospitals continue to face challenges with children and youth staying in emergency departments and inpatient units beyond medical necessity. So this means a medical professional has deemed the patient ready for discharge, but for a variety of reasons, they're not able to transition either to like an RTC or home, including foster home and group home. As of February 14th, there were approximately 59 of these children across Maryland who are stuck living in hospitals, nearly 29% in emergency departments. Approximately 73% are between the ages of 6 and 17. 39% are involved with DHS, either in the care and custody or they have an open case. Approximately 63% are waiting for an RTC, foster home or group home. The average length of stay in an inpatient unit after being cleared for discharge is 40 days. Children and youth in foster care tend to face longer delays and can essentially end up living in the hospital. There is legislation this session, House Bill 962, Senate Bill 696, which seeks to address this problem of youth boarding in hospitals by building in-state behavioral health capacity. There is a $5 million fiscal note, which we know is concerning, but we think there's several potential funding sources and expenditures that could offset the cost. And most importantly, changes could help keep Maryland children and youth from being sent out of state. First, in the operating budget, there's a recommendation to decrease funding for the Interagency Hospital Oversight Initiative by $1.9 million. We urge this committee to advocate against cutting this program in case these funds could be used to open up more RTCs. According to the Maryland Healthcare Commission, there are at least 17 licensed but unstaffed RICAs, which are state-run RTCs. Most of the youth who are stuck in hospitals are waiting for this level of care. Due to the lack of in-state residential treatment center capacity, Department of Human Services often pays to send children and youth out of state. Wrap up my statement. We just ask for your support and to protect some of the cuts in the BHA budget. Thank you for your time.
My name is Misha Christensen. I'm a client at Shepherd Pratt, so I feel I could, this is a place for me to tell my story because services for people with mental health issues is important. I have a story. I was adopted. They were bad people. I had a hit-and-run accident some years ago. I was supposed to die, and I don't have people to help me, so I need people to help me. So Shepherd Pratt is doing a very good job to help me fulfill my life. I have a whole story, but I just want to drop the line that it's an important thing. So please, keep this. You guys understand. Everybody already spoke for me. It's an important thing.
Thank you, members of the committee and the administration, for the opportunity to speak today. I'm Michelle Lifshin with On Our Own of Maryland. You heard from three of our wellness and recovery centers today, On Our Own of Frederick County, On Our Own of Calvert, and On Our Own of St. Mary's. We represent an affiliated statewide network of more than 20 peer-operated wellness and recovery centers that are funded through BHA. And last year, our network served well over 7,000 people living with serious mental health or substance use needs. Non-Medicaid grant-funded services like ours are integral and cost-effective component of the continuum of care. When people are unable to access traditional services due to financial barriers, transportation, fear, stigma, trauma, they're welcome through our doors. No referral, paperwork, insurance card required. Staff with lived experience and specialized training help meet people where they're at. We de-escalate crises and divert hospitalizations, and we create hope, trust, and healing. Most of our centers run on an annual award of less than $200,000 per year. We do a lot with a little, and we're so grateful for the past provider rate increases which boosted our budgets. But like our clinical colleagues, we are still understaffed and overloaded with people seeking support in these challenging times. When other programs get cut, are full, or closed down, peer support has always been there. As the state seeks a balanced budget, grant-funded community programs like ours, much like crisis services, fill the gaps in our system of care with creativity, flexibility, and innovation, and we achieve great returns on investment. Peer support turns barriers into opportunities, crisis into recovery, and struggle into purpose, and we're integral to supporting our workforce challenges. Please keep behavioral health funding whole and preserve the 1% proposed budget increase. Thank you.
And thank you. Colleagues, seeing no further questions at this moment, just wanted to kind of wrap it up with more or less comments. Deputy Secretary Moran, Dr. Lloyd. I think I speak on behalf of all of the respective committee. Just we deeply appreciate your partnership. From that standpoint, look forward to continuing ongoing conversations about some of the issues that we heard from that standpoint. To each and every advocate, specifically Ms. Redmer, who told the story about her husband, Gus, who spoke about your own specific experience. Gus Hughes is what I was trying to get out my mouth. And Ms. Capano, and a number of other folks that just kind of, it takes a lot of courage to come and speak your story to people that you do not know, why it is important. Just wanted to say that we hear you, we see you, and that it is important from that standpoint. And then to our sidekick, Ms. Naomi Camaro, just wanted to say thank you, thank you, thank you. Not only does she read out these reports, you all, but she and Philip are always helping to coordinate our respective committee and the assignments and the budget language and the committee narrative. And just wanted to say just thank you. And I just wanted to give you guys the opportunity. It's the last one that we'll have at this moment in case I missed anyone. And you're usually good at this stuff, Senator Zucker. So if it's anybody that I missed. Obviously, the trooper, you can shout out the trooper. He's been with us the whole ride.
No, I was just going to thank you, Mr. Chairman, and the entire committee. I know this work is tough. We're not here to do the easy work. We're here to do the tough work, and it's an honor to serve with you, Mr. Chair.
Same.
Thank you for your leadership throughout the session.
Yes, ma'am.
Appreciate it.
Well, colleagues, we look forward, to those that's out in the crowd, we look forward to working with you all as we go forward. This is the last HHS subcommittee hearing, and look forward to going back and forth with the House to make sure that we can get it in the right posture. Y'all have a blessed day.